Hello and good morning. I am going to do just a short board review just to kind of review some of the terminology. Uh, Not real heavy on the boards with dental materials, but this just kind of, in the past I've had comments that this short review, it has I shouldn't say short, there's a lot of slides in it, but some of them are question and answer format that I usually will do this in a game class format. So what I would recommend, just when you see the question, see if you can answer it, and then the next slide will have the answer and the rationale for you. Is the first question. All of the following are beneficial effects of fluoride, except one. Which one is the exception? So I do not have any Jeopardy music to play in the background, but I'll give you a few seconds to think about that one, and then we'll move to the next slide. So the answer on this one will be just another question. This has just kind of been on board exam examples. All of the following are found in dental amalgam except one. Which one is the exception? So I'll give you a few seconds to think about this one. There are still, from my knowledge, a few amalgam questions left on the dental materials in the National Board. There are, amalgam is still used. So at this point, we're still seeing amalgam questions on the board. So in this one, the answer, we have options of copper, tin, silver, and magnesium is the answer. Mercury, we had all of those. High corrosion and creep occur with magnesium. And this just gives some of the different components with the use of amalgam. We have high copper amalgam is what we see used today. The reason for that is low tarnish and corrosion. We have aspects of tin, silver, of course, which is a 40 to 70%, zinc, high copper amalgams. That's why they do not have zinc added to this, because there is no delayed expansion that can cause issues with occlusion or breakage of the tooth. And then mercury. I did put all of the chemical symbols in there as well. With mercury, and so there is a gamma phase silver alloy in mercury. That's when the mix, that's when your gamma phase 1 is the silver is reacting with the mercury, and that's when your amalgamation or the mixture of the silver and the other products is occurring. Question: the energy required to permanently deform a material is called. Give you a few minutes or a few seconds to look at the different aspects of this. And I know these are in the dental material books, and these are a lot of terms we discuss, but sometimes they don't make a lot of sense till we just kind of refresh and remind you about them. So here we go. The energy required to permanently deform a material is called brittleness, which that means it's just hard and likely to break or crack. The term resilience, it's resistant to the deformation. So think of that resilience or resistance. And the same thing, stiffness is pretty related to that as well. The modulus of elasticity, that's the measure of the stiffness of a material. Say, for instance, a bridge or a crayon has a high modulus of elasticity. It's very stiff. If you have a low modulus of elasticity, it has a lot of flexibility to it. And then hardness, that's the resistance to the penetration. Say, for instance, a crayon, we're not going to penetrate with our instrument very well. A lot of questions in this, and again, usually I play this in a game format, so I'm and then we discuss the questions as we go along. So I'm sorry we didn't get to do that game format. So next question, which of the following impression materials are elastomers? We have alginate, polysulfides, agar, addition silicones, and polyethers. So I'm just going to jump to the next slide and let you look at that. And which of the following impression materials are elastomers? So think of these as elastics. Elastomers are rubbery, but they're dimensionally stable. And these elastomers are usually used for maybe a denture impression or a crown and bridge impression. It's not like the use of your alginates. Your alginate material actually has the agar. Those two are why they are not selected. The polysulfide is most often used for dentures. The addition and condensation silicones are used more for crown and bridge impressions. And a polyether is also used more for a crown and bridge impression. Another question. A steady cast is a positive reproduction. An impression is a negative reproduction. I'm going to let you look at this one, think about it for a second, and then we'll go. Question. Susan recently had an MOD amalgam placed in tooth number 3. This tooth was temperature sensitive for about a week, and the sensitivity has subsided. This temporary hypersensitivity was most likely due to galvanic current, traumatic occlusion, pulpal hyperemia, or chronic pulpitis. So to discuss this question, our first answer is not popping up, which was galvanic current. That is a temporary hypersensitivity, so sometimes that's a selection. But the galvanic current is due to two dissimilar metals touching. So always think about that. So that would not be an answer. The pipe will be a correct answer. It might be a thought because it is temporary hypersensitivity. The pulpal hyperemia is excess blood flow to the area, and it's reversible. A lot of times a deep amalgam, which would be an MOD restoration, this could also be an example with a composite, the tooth may be sensitive for about a week or two. But usually it subsides, especially if it was a little bit deeper restoration, and they had to put a base in there or some type of insulation. The traumatic occlusion and the chronic pulpitis, those are items that will not be reversible. The traumatic occlusion, you have to adjust that occlusion. Say, for instance, if your restoration or your sealant has been too high, and it doesn't wear, you have to adjust that and it will cause sensitivity. And the chronic pulpitis, again, if it's chronic, that is not going to be temporary. It's going to keep on. So kind of think of that. Dam placement allows the dentist to achieve and maintain a dry field by isolating the tooth for treatment. Think about that statement. The rubber dam prevents the patient from aspirating dental materials that are used during the procedure. And think about that statement as we go to the next slide. And both statements are true. It does prevent aspiration, and it also achieves that dry field and prevents bacteria from getting into the area, especially for endodontic procedures. Following are indications for porcelain veneers, except one. Which one is the exception? So let's look at these different answers. Coverage of the labial surface defects, hypoplasia of the enamel, for example. Masking of colored teeth, tetracycline stainings, discoloration due to the loss of vitality. Number 3, the repair of structural damage. Do they have some fractured incisal edges? The severe imbrication, and that term means overlapping. And I had seen this in a previous national board question called imbrication, and I didn't even know what imbrication was and had to look it up, and it means overlapping. And then improvement of tooth contour. Say, for instance, they have some peg-shaped laterals and different size teeth in the anterior, and they need those more consistent and normal sized. Or number 6, reduction of spacing in cases where orthodontics would be inappropriate. So let's just look at those. We're going to go to the next one. And out of all of those, we kind of discussed those. The severe imbrication is the correct answer. And one thing porcelain veneers will not do is correct severe overlapping. That has to be either done by crowns, where they reduce and reshape the teeth, or they have to do that per the use of orthodontics. And this is just a review of the different types of endosseous implants that are out there. Some of these, I just kind of mentioned these. We have the subperiosteal, the transosteal, and some of the older type of implants like you see right here. That's called a blade implant. Sometimes these subperiosteals can be used to maintain a denture, like here, here, and the denture would snap in. Nowadays, they tend to use more like what this one looks like. It's called a mini implant. Again, these older implants like this are called a blade implant. You really don't see those used today. And these are images of what we see more used today, our type of implants. Here is our implant, our endosteal implant that's mainly made from titanium. And then here is our screw or our abutment that's going to anchor it. And then here's your crown that attaches that to that. And nowadays, you'll see, especially in anteriors, I just kind of mentioned these, where here's a titanium implant, and those are great for a posterior, but sometimes what would happen is you would kind of start to see some of the implant here along where that abutment was. So now they kind of have some of the zirconia abutments, so you don't see that silver line at the top of the implant over a period of years. A dental cement is mixed to a blank consistency and used as a luting agent and a low strength liner. So these I would definitely be aware of: your primary consistency, secondary consistency, whether it's a base or provisional. So kind of look at those answers, pick yours out, and we're going to discuss these. Okay, a dental cement is mixed to a primary consistency. We're going to discuss these. That is a honey-like consistency. It has to be thick enough. And a luting agent, if you see that term, luting means cementation. And they'll use some of those terminologies. Low strength liners, the primary consistency, a liner, they would put that at the base of maybe a restoration because it may have some fluoride releasing agent. Secondary consistency right here, that's going to be more putty, thicker, and they a lot of times will use that as a heavier duty, stronger base liner or a base for a to protect the pulp, like is mentioned here. So the base may be very thick, mixed in a secondary putty-like consistency. And a provisional restoration basically means that's something that is temporary. It's not put there on a permanent basis. The following is regarded as the most important sign of an implant failure: patient discomfort, bleeding on probing, mobility, or scratched implant along the surface. Again, what is the most important sign? And that is mobility. Remember, if we see bleeding on probing, that is not necessarily implant failure. That might be some peri-implantitis, and sometimes we can cure that peri-implantitis around there, or some patient discomfort if there's inflammation that is around that tooth, or a scratched implant necessarily is not going to mean that it's implant failure, but mobility of an implant is going to mean that there's some big problems going on with that implant, and it's probably not going to last very long. Thermic reaction is observed in the setting reaction of zinc phosphate, zinc polycarboxylate, glass ionomers, or zinc oxide eugenol type of cement. Now remember, exothermic gives off heat in that setting reaction. So we'll move to the next slide. So an exothermic reaction, which is giving off heat, is observed in a zinc phosphate. That's why some of those, if you remember discussing this in dental materials, some of your cements need to be mixed on a glass slab. And that's because of that heat that's giving off. And also no ceramic cementation, any type of ceramic materials like a lithium disilicate or a zirconia type of restoration is going to be used with a zinc phosphate cement. A zinc polycarboxylate cement can be mixed on a glass or a paper, has a short working time, high solubility, low compressive strength. We don't really use those quite as much. It's an older, one of the older type of cements that are out there, but it still is used more so in orthodontics. Our glass ionomer cements, those are fluoride releasing. They do not necessarily have an exothermic reaction. They're most known for their fluoride releasing, and it actually chemically bonds well to the tooth structure. So glass ionomers are very popular because of that. Biggest drawback in using those, especially for restorations, is they are moisture sensitive. Zinc oxide eugenol, that has a sedative effect. That's like sometimes that's that clove scent that dental offices have from the eugenol. Sometimes there'll be some eugenol free because some people are sensitive to that. A zinc oxide eugenol can also be used as a provisional or an intermediate type of restoration or some type of temporary restoration. Remember, that's what the provisional restoration is. And zinc oxide eugenols are sedative. So they may put that restoration in as a temporary to settle that tooth down and evaluate it because it may not need a root canal if it heals itself because of that sedative restoration. Resin base, that's a lot of times we'll see that for ceramic restoration, but sometimes they'll use a self-adhesive as a resin-based cement or so they don't have to do the etching and the priming. Remember, you may have and I have these in the notes, the exothermic gives off heat. You may have a self-cure cement that you have to mix two chemicals together. It's chemically activated. Again, you may have a light cure, just like you have for your light cured sealants. There's light cured cements. And then sometimes we have a dual cured cement, and that's going to use both light and a chemical reaction. And you may light activate it to start, and that reaction starts, and the rest of it is cured chemically. Where should alginate impressions be disinfected? In the lab before leaving the treatment area, when you just have time, and really it's not that necessary because we're going to rinse and disinfect this. Next answer. Before leaving the treatment area, I hope everyone had that one correct. We're not going to do it in the lab. We always need to rinse that and disinfect that for 10 minutes before leaving our treatment area. And always remember before pouring these up to rinse them and dry them out really well to remove all of that moisture so you don't have air bubbles. The wax listed below is often added to alginate impressions to customize the fit of the tray for patients' needs. Is it a base plate, a boxing wax, a sticky wax, or a utility wax? Think about that one for a second, see which one's your answer, and we'll discuss each of these waxes. It is the utility wax. Hope everyone got that one right. Remember, this is those little wax strips. It can either be a thin red or it might be a thin wax. This is also utility wax. Can sometimes be known as a rope wax. This is what can also be stuck on, if you use the clear, you used on your braces. This just kind of shows the different waxes. Here's a base plate wax, and you may have used this wax to use one of your wax bites. Your boxing wax, that's basically boxes around an impression, and it helps us make one of the bases where you don't have to use that inversion or that cow patty method. And then here's a sticky wax, and that one really, as hygienists, we don't use that often. They might use the sticky wax more for crown and bridge type of procedures when necessary. So this one, how many scoops of alginate powder are used for a maxillary full arch impression, and how many scoops are used for the mandibular? I'll let you 4 scoops and 3 scoops, 3 scoops and 4 scoops, 3 scoops and 2 scoops, or 2 and 2. Remember, in our packets that we have in the clinic, each of those are 3 scoops, and you don't always have to use every single one of those. So choose your answer. We're going to the next slide. So that would be 3 and 2. For a normal arch, 3 scoops of alginate powder are used for a maxillary full arch impression. 2 scoops are generally used for the mandibular arch. Usually when you get into practice, you're not going to have those nice little packets that we have. They're going to be in a normal size tub or container. You actually have to look at the patient's arch as well, because and again, that's going to be for a normal size maxillary full arch. If they have a little bit smaller arch, usually 2 and 2 are okay. But as a general rule for a normal arch, 3 scoops and 2 scoops. Next, about alginate again. Alginate trays should be fitted to the patient's mouth to cover where? All of the above, or maxillary tuberosity, retromolar area, height of the anterior and posterior teeth, or all of the above? And I think I gave that one away. All of the above is the correct answer for this one. We want for the maxillary tuberosity on the maxillary, the retromolar area on the mandibular, and the height of the anterior and posterior teeth on the complete impression. Remember when we've had to retake some of the impressions because you did not have the complete line of all of the teeth, and we would not, if you were trying to fit your whitening tray, we would not have the complete height of that at the gingival line for those teeth to get a really nice fit for your tray. Mixing alginate impression material with cooler than room temperature water will result in what type of gelation? Will it lengthen and accelerate? Will it shorten and accelerate? Lengthen and retard or slow down the reaction? Or shorten and slow down the reaction? And mixing it will lengthen and retard or slow down the gelation process. Remember, if we use cool water or have a cool room temperature, or there's cool weather outside, it may really lengthen and slow down your setting process. And again, if you're using a warmer water or it's higher humidity, sometimes it's going to accelerate that process when you're taking an impression. The acid etch technique. What does that do when we're etching the tooth? Does it conserve the tooth structure, reduce microleakage, improves aesthetics or how the tooth looks, or does it provide a micromechanical retention, or does it do all of the above? Think about those for just a second, and This provides a micromechanical retention. Be clear on the difference on these. Remember that the micromechanical, when you make that frosty look, when you etch the tooth, for instance, you're doing your sealants, that's going to cause a direct retention. So when you do a sealant, that is called a micromechanical retention. We're roughening up that tooth surface so that resin from that sealant will flow into that into the tooth. Where if you have chemical retention, that's if you have, say, for instance, when you did a composite, if you think back to that example, the tooth is etched, then you put the bonding agent on there, and then you cure it, and then the composite is placed on top of those. Some of those are a self-bonding agent, but that is still a chemical that it's going to bond to the bonding agent. The micromechanical directly bonds to the tooth. Those are two concepts right here you really need to know and need to remember. What is the main difference between a liner and a base in a tooth? Liners are used, A, to replace missing dentin. Bases are used in a thin layer to replace missing dentin. Really, there's no difference? Or it's a liner is a thin layer to aid in repairing reparative dentin. In this one, it is D. The difference in this, liners are not used in bulk. They're going to be real thin. It's a thin layer, and it helps promote reparative dentin. And if you remember using the Di-Cal and you mix those two together, and that is what's called a liner. And a lot of times that's placed beneath a restoration to help promote reparative dentin. Bases are the ones that are going to be very, very thick, and they're going to be to that secondary consistency. So there is a difference between the two. This just says the calcium hydroxide difference is kind of the material that is actually used. There's your another for the high strength, and that gives. Next question. All of the following are contraindications, which mean it's not good for implant placement except one. Do we have pathology? Presence of limiting anatomic structure, unrealistic expectations, poor oral hygiene, inability to keep it clean, a gag reflex, or uncontrolled metabolic disease or an acute illness. Sometimes we have uncontrolled diabetes, for instance. And really, that's your exception. It's not going to make a difference if they have a gag reflex or not with placing an implant. It might when they're getting an impression, but a lot of times the anesthesia can help with that. High noble metals, which are used in fabricating metal ceramic restorations, are which percentage? Sometimes this one has been asked. I've seen it. I hope they do not ask that. So we're just going to kind of go to the next one because that gives you your answer. 60%. Noble metals are gold, platinum, and palladium. Something that is a noble metal, that they must be 60% gold. Noble metals, again, they're not used that often, gold, platinum, and palladium, because they're very, very expensive. So that's why a lot of times we're seeing more zirconia that is used. The final mercury content of a properly placed high copper amalgam restoration is A, B, C, or D. And we'll just look at that because somebody might know this answer, but we're just going to look at it real quick. And it is 42 to 52%, the final mercury content. Again, those are high copper amalgams that are used, and they don't have that gamma 2 phase. Think of that. Amalgamation Just know that term is a reaction with mercury. The metals actually dissolve and crystallize into that mercury when you're looking at using the silver and the copper. That's how that amalgamation reaction occurs, when it crystallizes in with that mercury that starts with your liquid. Another amalgam question. High copper amalgam alloys are superior in clinical strength. They display reduced corrosion and do not have, see if anybody remembers this. I mentioned it in the previous slide. A, gamma 1, B, gamma 2. There's no difference, or a high copper content. High copper alloys do not have a gamma 2 phase. And again, that helps their strength and that expansion. It makes it safer in the tooth, so they don't have cracking of the tooth structure itself because they've gotten eliminated that gamma 2 phase. Which of the following professional office fluoride treatments should not be recommended for a patient with bulimia nervosa who is purging? A stannous fluoride, a neutral sodium fluoride, an acidulated phosphate fluoride, or really it doesn't matter. A, B, C, or D. Think about that. Think of the names of the type of fluorides. And it would be the APF, or the acidulated phosphate. We don't really see this when used quite as much today, but again, if someone has bulimia or they're purging, they've already got that acidity, we're not really going to want to put an acidic fluoride on top of there. Neutral sodium fluoride or a stannous fluoride are fine, but I have heard some people mention that that might still be included on the board, so I just included that one. Selective polishing, kind of think about what selective polishing is employed to lessen enamel reduction. Coronal polishing removes fluoride from the tooth. A, B, C, or D? We're just going to move right into the next slide, and both statements are true. Selective polishing is employed to lessen enamel reduction, because remember, we can, with our abrasivity, remove a little bit of that enamel, and then coronal polishing also removes fluoride from the tooth. So when we use selective polishing, we're trying to, and this was very popular, it really wasn't widely accepted by patients, because as we remember, patients think if we're polishing their teeth, that's cleaning their teeth. We could still use selective polishing, especially if patients are sensitive, by all means, but it does help to remove lessen that enamel reduction. Coronal polishing does remove a little bit of that outer fluoride from the tooth, which is again why we watch the abrasivity of our types of polishing agents. Characteristic of color refers to the color families. Remember, red, blue, and color shading is in our light. Is it chroma, hue, value, or metamerism? And I'm just going to move on with that one. Hue. Which characteristics? So when we have chroma, that's going to be the intensity. Look at our that's going to be pastel view versus a royal view. Our hue is going to be the color, just the basic color that you see, whether it's red, blue, yellow. That's a hue. The value, it's going to be the brightness. It's bright blue, or does it have shadows with it? Metamerism, that's a term that we see the color looks different in different lighting. For instance, if, you have a paint color, looks great in one room, but then you get in a different lighting and it looks terrible. Or it looks too dark. And that's, again, why we look at some of the napkin colors. Remember, we like a very light gray or a blue to kind of help neutralize those colors due to the metamerism and get a good shade. Or sometimes there are specific shade lights to help choose a lighting or a color of a tooth or a shade of a tooth to prevent that metamerism. Which of the following is the most irritating to the pulp of a tooth? We kind of mentioned this one earlier when we were looking at some of the different cements and compounds. Is it the ZOE, which is the zinc oxide eugenol, calcium hydroxide? Remember, that's a sedative agent or a liner. Excuse me, not a sedative agent, it's a base or a liner. Zinc phosphate or a glass ionomer. Go to the next one. We'll discuss these. Hopefully everybody remembers and chooses the correct answer for this one. It is the zinc phosphate. We're not going to use that one for a base or a liner because it has a lot of post-op sensitivity and a lot of pulpal irritation. And that is probably a cement that is not used very much anymore. It's more just a cement. The zinc oxide eugenol, we can use that as a temporary cement or a provisional restoration. It has that sedative effect. The calcium hydroxide promotes reparative dentin. Remember, that was our dical or a liner. And the glass ionomer, that's fluoride releasing. So it might have a little bit of sensitivity, but it really does kind of help. We like that for the post. It's not necessarily, we can use it for direct bonding to a tooth. We just have to watch out for the moisture. Next question. All of the following are contraindications to the placement of sealants except one. A, B, C, D, E, or F. Think about that. Look at those. And next one. C. If we can't hold someone still, we're not going to, and keep that tooth dry, we can't get a good sealant. We're not going to, definitely, I hope everybody got that. We knew that we're not going to put a sealant on a carious lesion. E, D, and F. Let's kind of just think about those. Those are things, that one's not too bad, but that one we know if they have deep pits and fissures, we're going to put a sealant in that one. All the others are contraindications. Next question. Cami has just finished placing sealants on the following teeth, 3, 14, 19, and 30. Which of the following is not necessary after a sealant? A, don't eat anything. Check the bite or occlusion. Check the sealants for any voids or irregular areas. Floss the interproximal areas. Which one do you think? A, B, C, or D? Okay, A is the correct answer. We are not going to tell a child, usually we do these on children, that they're not going to eat anything for the next 6 hours. But we do need to check that bite for any occlusal interference or if it's high. Check the sealants for any voids or irregularities. And also make sure you always floss those interproximal contacts. We don't want our patient to get home and not be able to ever floss again because we have overflowed into that contact area. Next question, proper luting consistency. Remember what's luting meant. Remember what luting is that's going to be cementation in a dental cement is achieved when the material is putty-like on the spatula, flows like a little thread from the spatula, firm and solid, or the consistency doesn't really matter. And again, this is for cement, for cementing a crown. That's what luting means. It's going to flow in a thread-like primary consistency. Remember, it's going to be honey-like. If it is putty-like, it's not going to really work for a cement. That's going to be more if we're using it for a secondary restoration. If it's firm and solid on the spatula, again, that means it's already set up. So we're not going to put our cement on with that. So really the consistency does matter. And again, luting means we're going to cement something on there. Zinc oxide eugenol may exhibit all properties except for, is it a sedative agent? Does it smell like cloves? Is it a long-term, temporary, or provisional restoration? And will it interfere with the polymerization of a resin cement? Zinc oxide eugenol may exhibit all of the properties except for, we do not use it for a long-term provisional restoration. Remember, that's a temporary. They are short-term restorations. It definitely is a sedative agent. It does smell like cloves if it has eugenol in it. Sometimes we do have eugenol free. And if it's on a tooth, it can, and it's not cleaned well, it can interfere with the polymerization, or remember, that's curing of a resin cement that we might use for the permanent cementation. Which of the following is the principal feature of a successful sealant? High viscosity? What's that term mean? Adequate micromechanical retention. Remember, we discussed that earlier. An added colorant to make the sealant slightly different, or the use of a rubber dam. Which of the following is the principal feature of a successful sealant procedure? B, we have to have good, adequate micromechanical retention. So basically that means we really have to etch that tooth well. Remember, we discussed the difference between the micromechanical and the chemical retention. The chemical retention is the bonding agent and the material for adhesion. So the micromechanical is just the tooth basically has been etched, and we're going to get that sealant to adhere to the tooth properly. So we have to have adequate etching time for micromechanical retention. Which of the following is the main use of a cavity varnish? Thermal insulation, stimulates secondary dentin, used in bulk replacement, protects against galvanic shock or current, and used to seal dentinal tubules. And used to seal dentinal tubules is the correct answer. Varnishes are seldom used today. I put this in a question just because it's still in your textbook, and I've seen this used in some sample questions from the board review book. Thermal insulation is not for a varnish. That's going to be for a base. Secondary dentin is going to be with your dical or a calcium hydroxide. Used in bulk, it's not going to use that in bulk for a varnish. It's a very thin. Remember, think of your varnishes that you use for a fluoride varnish, how thin it is, and that's the same thing with a cavity varnish, but it's usually placed under a restoration, and it does not prevent against the galvanic current. Remember, that's two dissimilar metals that are touching one another. Most in-office whitening systems use light-activated solution of hydrogen peroxide, 15% hydrogen, 25 to 35%, or 80%. Remember, this is in-office whitening systems. And the in-office whitening systems are usually 25 to 35% hydrogen peroxide. You very seldom are going to see the 10%. 10 or 15% are going to be some of the take-homes, and usually that's just way too high. No one is going to use an 80% hydrogen peroxide. But again, your 10% and 15% are seen in your take-home products, and the 25 to 30% are put into the in-office whitening procedures. The constituent, or the ingredients in an alginate powder, which is called an irreversible hydrocolloid that functions as a filler to increase the thickness, is a trisodium phosphate, diatomaceous earth, calcium sulfate dihydride, or a potassium sulfate. And I'm guessing just everybody's going to get this one right off the bat. So we're going to go to the next slide to find out the answer. And it is B, diatomaceous earth. Remember, our alginate is irreversible. Once we mixed it up, we can't take it back. Just a reminder of that. And diatomaceous earth, that is just a filler that is used in an alginate, and it's going to kind of give it thickness and strength. The calcium dehydrate, that has more to do with your stone, and these both are all tend to deal a little bit more with other products. There is the joining of metals by the use of a filler metal material, substantially lower fusion temperature. Again, this was more of a sample board question from one of the board books. I'm going to go straight into the answer on this one. And it is called soldering. If anybody's ever got any parents that works with, or boyfriend, or someone, grandfather that works with metals, they have a little soldering gun or soldering iron to help repair metals. The heating of metals, sometimes that's going to be more for crown and bridge. This might be used in a lab. All of these might be used more in lab materials. This is just a little funny, just to make you smile. You are all great philosophers. Which of the following is a alloy that tends to reduce the setting expansion of amalgam? Decrease the silver content of the alloy, increase the silver content of the alloy, increase the trituration or the mixing time. Remember, trituration means mixing, or addition of tin. Ding, 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 ding. I wish I had my Jeopardy music. Correct answer is the addition of tin. That helps to reduce the expansion time of the amalgam. Remember, amalgamation is the mixing of the different powders. Increasing the silver decreases the setting time. We don't want to increase the trituration time, but we're going to emergency treatment in the dental office for a patient who has accidentally ingested a large amount of fluoride would include all of the following except, which one? Induce vomiting, call 911, crush an ammonia capsule under their nose, or have the patient drink large quantities of milk or other calcium-containing liquid. And you might have reviewed this already in prevention and already have zeroed in on the answer. I just mainly included this because fluoride is included in your dental materials discussions. You are not going to crush an ammonia vapule underneath a patient's nose to keep the patient, but you may induce vomiting, call 911. Usually most of the time have the patient drink large quantities of milk or other calcium containing liquid to bind that fluoride would be the first thing, then call 911. Kind of a case study question. Today was a very busy day for Mary, the dental hygienist in our office. Mary took alginate impressions on her first patient in the morning who needed an eye guard. Since she was so busy, Mary left the alginate impression in the lab for most of the morning. Then she decided to place the impression in a bowl of water so it would not dry up before she had a chance to pour them in her dental stone. Which of the following was the result of Mary leaving these impressions in water for the next several hours? Gelation, adsorption, syneresis, or imbibition? These are terms you will probably need to be familiar with, and we're going to discuss them in the next slide. So hopefully you know all these terms and you've already chosen the right answer. And it would be, correct answer is D, imbibition. Excess water can distort the impression. Imbibition, or it imbibes, it's soaking up that water. Syneresis is loss of moisture. If Mary had left that impression sitting out and didn't have any moisture around it, so that's going to dehydrate and distort or take that water out. Adsorption is also going to be, maybe if she did wrap it in a paper towel, for instance, and she got a little bit of moisture on it. That's fine, but it's going to have excess moisture on the surface, but it may not have imbibed it because it hasn't been there for several hours, but you get some water on there. Gelation, it's already set up, so we don't have a gelation reaction in there. We have the imbibition because it's distorted that for too much water that she left it sitting in. So that's the reason we don't soak it in a bowl of water. We mainly just wrap it in a moist paper towel and put it in a plastic bag if it's going to be any period of time before we need to pour it up. The ability to withstand permanent pulling or stretching under compressive strength without rupture is referred to, hear more of these terms, ductility, malleability, shear strength, and ultimate strength. A, B, C, or D. And that is ductility. So that's going to be stretching or pulling. Malleability, it's compressed into a thin sheet. Shear strength is when kind of biting. You have shearing strengths with the way your teeth, two forces come together. And the ultimate strength is the maximum stress a material can have before it breaks. So ductility and malleability are pretty similar, but the malleability, it's compressed just into a thin sheet of material, where ductility, you're going to pull it or stretch it out before it breaks. For instance, the ductility of your alginate material is pretty weak. Here is the examples for that. And there again, I just put that one in there. That wasn't one of your answer selections, but the modulus of elasticity refers to that rigidity of a material. We really want a strong material for crown and bridge, or for instance, our alginate material has a very low modulus of elasticity because it has that rubbery, less precise movement. It can be damaged very quickly or easily. Next question. I know I'm moving through these quickly, but we had a lot of slides. Which of the following characteristics of amalgam would explain why cold sensitivity is the most common problem encountered after placing a dental amalgam restoration? And sometimes this is true of a composite as well. A, coefficient of thermal expansion, biocompatibility, thermal insulation, or D, all of the above. Think about what each of these terms mean. We're going to go into the next one. And it's going to be A, your coefficient of thermal expansion. And that's the change in volume with the change in temperature. Basically, when there if the amalgam or the composite is not placed properly, that coefficient of thermal expansion is going to change that volume or the size inside the tooth, basically, if it's not set properly. And it can actually, with changes in temperature, be very, very sensitive. Biocompatibility, most of the time these are very biocompatible, the dental materials. You will read some things about mercury toxicity due to dental amalgams. That's a whole nother project that we could talk about. But usually your composites and your amalgams or dental materials are very, like zirconia, your metals, are all very highly biocompatible. Thermal insulation, that sometimes is not the most common problem due to restorative materials. That is more if it has a deeper restoration, but we see more of that measurement of change in the volume. Which of the following acids are used to etch the enamel? I know you all know this. I'm going to go to the next one because everybody knows that's phosphoric acid. It's not acetic acid. It's not boric acid. No, it's not nitric acid. It is phosphoric acid. Dr. Miles, I gave myself my doctorate, is about to perform restorative work on a patient. In which of the following cavity preparations is use of a wooden wedge unnecessary? Got to know our Black's cavity classifications for this. A, B, C, or D? Class 3, 4, or 5, 2, 3, or 4, 1, 3, or 5, 1, 4, or 6. This one is D, a class 1, class 5, or class 6. Remember, a class 1 is an occlusal. Class 5 is at the cervical line or that marginal area. That can be on an anterior tooth. It can be on a buccal surface, and it can also be found on a lingual surface. A class 6 is going to be a cusped tip. A class 3 is an interproximal on an anterior tooth that does not include the incisal edge. Class 4 has the incisal edge. Those are going to have some type of mylar strip in between and often has a wedge. Class 2 is going to be on a posterior tooth, and that's always going to have to include a wedge. That could be a DO or an MOD. How are the SDS sheets, the safety data sheets used in the dental office created? Does the hygienist create them? Does the dentist create them? Does the manufacturer create them? Or is it a contribution of both the dentist and the hygienist thinking that, these are ideas for the safety of the office team? Correct answer is C. These are always included with from the manufacturer. They should always have a safety data sheet. Sometimes you may see these referred to in older materials as material safety data sheets. You should have these in your office accessible somewhere. There should be a binder. There should be something that you can always look up a safety data sheet if there is something you need to look up for contraindications for a material or safety of a material. Polishing a composite restorative material. Which of the following should never be used? Remember, because we're hygienists, we want to take care of these composites. Tin oxide? Do we use a coarse pumice? Do we use a diamond paste? Or do we use just a toothpaste? But which one of these should we never, ever use? Of course, we're not going to use a coarse pumice. A tin oxide can be used to polish a composite, not necessarily when we're doing a prophy, but that can be used to polish and smooth out any imperfections on the restoration. A diamond paste, very, very thin polish that can be used to increase the luster of a scratched composite. A dentifrice toothpaste, we could use those. Again, we don't want to use one that's too abrasive, and we're always going to watch for that with our patients and recommending. But we never, ever, when we have a lot of cosmetics, we're not going to use a coarse pumice on that, and you really need to be aware of that as you get into practice and use your materials accordingly on cosmetic restorative surfaces. Next question, dental adhesive resins may be which of the following? A bis-GMA, a urethane dimethylmethacrylate, a triethylene glycol dimethacrylate, or all of these correct bonding resins? An adhesive resin, remember it's something that's going to be, a resin is going to adhere to the tooth. All of these are bonding resins. If you see something that is a methyl methacrylate, that's the key in this. Anything that says methyl methacrylate is going to be some type of bonding agent. That's all really I'm going to go into on that. Just as you see something that has a methyl methacrylate, it's going to be a bonding agent. Study, study, study. I know you guys are studying so hard. And I want you to do well. I know everyone will do well on your upcoming board. Next question, on to moving on to the next question. In the United States, which of the following agencies must provide approval before a material can be marketed for dental use? Is it the International Organization for Standardization, the ADA, the OSHA, or the FDA? Which one of these? This one, I can tell you, in some way, shape, or form may show up. So be aware of this one. And I hope everybody got the right answer. And that would be the FDA, International Organization for Standardization. That's not so much here in the United States, but more in Europe, Canada. American Dental Association does not have to have approval. The International Organization for Standardization, that's not really United States, that's more international, so think of that in that term. ADA does not look at dental materials. OSHA does not look at the dental materials for marketing, but the FDA does control any type of dental material for consumer use, and there are some that drugs for consumer use as well. Even our, say, toothbrushes are under jurisdiction of the FDA. Devices, over-the-counter projects, Class 1 type, or what are called Class 1 materials, such as gloves and prophy pastes. Class 2 are amalgams. Class 3 would be implants and bone grafting materials. Next question. An increased water powder ratio or more water will affect the gypsum material or mixture and final cast in what way? Will it increase its strength, decrease its strength, increase the abrasive resistance, or decrease the setting time? And the answer is it's going to decrease the strength. Increasing the water powder ratios of gypsum, and that's your stone, or some type of gypsum product, whether it's the white stone, your yellow stone, your pink stone, increasing that water powder will decrease the strength, hardness, and abrasion resistance, but it will increase the setting time. Which form of mercury is the most concern for dental professionals? Vapors, droplets, combining it as a metal alloy, or the metallic mercury? And that would be A, vapors through the inhalation route. That is one of the reasons there is so many restrictions on the removal and the safety of removing old amalgams to keep that vapor out of the offices and anybody, especially dental personnel, from inhaling those vapors. Which of the following is utilized as a primary monomer in fabricating denture bases? Remember the methyl methacrylates. These were all methyl methacrylates. And the methyl methacrylate on its own is the primary monomer. All of these others, the tegma, the bis-GMA, the UDMA, those are all longer form monomers that, polymers, more plastic-like materials. They're going to be in your composites. Which can be done to decrease the working time in an irreversible hydrocolloid material. Remember, that's our alginate that is irreversible. So just remember, irreversible hydrocolloid is going to be an alginate. So we increase the water powder ratio, decrease the water powder ratio, use cooler water, use warmer water. So we want to decrease that working time of the alginate. So we're going to use a warmer water because that's going to make it set up a lot faster. I know some people that can really use some very warm water and do impressions just like that. I'm in awe of them because they can take such good impressions just like that with that warm water. But sometimes that's not all of us can do that quickly, but sometimes we do have to use a warmer water to shorten that due to a gag reflex or something along that line. A blank is a bone graft from a cadaver bone, while a blank is a bone graft from a patient donor. Allograft, autograft, xenograft, alloplast, general graft, biplast, autograft, or a xenograft. And our answer is an allograft. And an autograft is a bone graft from a patient donor. The allograft is a bone graft from a cadaver bone. An autograft is a bone from the patient. An allograft is a cadaver bone. An alloplast is synthetic bone. And a xenograft is made from cow or pig bone. Of the following materials, which has the greatest ultimate tensile strength? Gold, composite, dental amalgam, or zinc oxide used genol. Think of those all together. Which one is, we've got gold, composite, amalgam, or ZOE? Gold. A gold alloy has the greatest tensile strength, and that's through stretching. Tensile is going to stretch it out. Remember, our golds are a little bit thinner and a little bit more malleable. Composites, we're not going to have a good tensile strength. Those have a little bit higher modulus of elasticity. Same with amalgam. Zinc oxide eugenol is not got a high modulus of elasticity, but really we're not going to have a lot of tensile strength with that because it's just going to break quite easily. Oh, same with amalgam or composites. Oh, we made it to the end. I've tried to go very fast as a review for this. You've got this. When you're in dental hygiene school, I know you guys are just looking like this. Stay positive. You're almost there. I know you can do this. And if you have any questions, please touch base with me.